Welcome to This Week in Allergy and Immunology. This week we're covering 10 notable papers spanning drug hypersensitivity and perioperative anaphylaxis, asthma and upper airway treatment strategies, and new mechanistic work on food allergy trajectories. Let's dive in. We start with drug allergy, where the European Academy of Allergy and Clinical Immunology has published 2 companion documents in allergy that together reset how we diagnose and describe these reactions. The updated statement on drug hypersensitivity skin testing, led by Barbo and colleagues, standardizes methodology and gives validated non-irritant concentrations across the major drug classes we actually test, including antibiotics, contrast media, anesthetics, proton pump inhibitors, chemotherapies, and biologicals. Several points matter at the bedside. For immediate reactions, the optimal testing window is 4 to 6 weeks after the reaction, and testing beyond 6 months increases false negatives, although chemotherapy reactions still need earlier assessment within about 2 weeks because treatment cannot wait. The reference method for reading a positive immediate intradermal test is now explicit. Inject exactly 0.02 milliliters and call it positive when the wheal at 20 minutes is at least 3 millimeters larger than the initial wheal. For patch testing, the guidance warns that crushing tablets and diluting them at 30% in petrolatum produces substantial variability in the actual concentration delivered, so active ingredient concentrations should be documented systematically. Critically, for delabeling practice, risk stratification now permits direct drug provocation for mild maculopapular exanthema without preliminary skin testing, while anaphylaxis still requires skin testing first, and skin tests are described as useful and safe for identifying the culprit in severe delayed reactions, including DRESS, acute generalized exanthematous pustulosis, and Stevens-Johnson syndrome, or toxic epidermal necrolysis. Alongside this, a position paper from Torres and colleagues proposes a new nomenclature for immune-mediated drug reactions. Their argument is that the Gehlen-Coombs framework no longer explains what we see in contemporary practice, and that phenotype alone cannot tell you the endotype. They split immune-mediated reactions into drug allergy, meaning antigen-driven reactions diagnosed by tests that detect sensitization, and drug hypersensitivity, meaning the broader group of reactions driven directly by the drug's interaction with immune or inflammatory pathways. Expect this vocabulary to start appearing in journals, pharmacovigilance reports, and trial protocols. Staying with severe reactions, the Journal of Allergy and Clinical Immunology in Practice reports a pre-specified analysis from DeWachter and colleagues of perioperative IgE-mediated anaphylaxis across 2 academic centers. Among 72 patients with grade 3 or 4 reactions, 27 showed what the authors call the early cutaneous vasoconstriction phenotype, and all 6 fatal or near-fatal outcomes in the cohort occurred in that group. That works out to roughly 1 in 5 patients with early vasoconstriction dying or requiring mechanical circulatory support, against none of the 45 patients with vasodilation or no cutaneous signs. In every one of those 6 cases, vasoconstriction was accompanied by bradycardia, with a median heart rate in the mid-40s. The authors interpret this as a marker of profound hypovolemia and greater initial severity, and they suggest that purely symptomatic treatment, given without regard to the underlying mechanism, may have contributed to the poor outcomes. The practical message for anyone who consults on perioperative reactions or who teaches anesthesia colleagues is that a pale, cold, bradycardic patient is not having a milder reaction than a flushed one. It may well be the opposite. Turning to asthma, 3 papers this week question how well our current strategies actually work. In the Journal of Allergy and Clinical Immunology in Practice, Kang and colleagues report a multicenter, open-label, randomized crossover trial asking whether a long-acting muscarinic antagonist could substitute for inhaled corticosteroid in type 2 low mild asthma, defined by blood eosinophils under 300 and either low fractional exhaled nitric oxide or low sputum eosinophils. Of 150 patients randomized, 89 completed both 6-month phases. In the per-protocol analysis, treatment success was about 8 percentage points higher with the muscarinic antagonist, and non-inferiority held in 2 intention-to-treat analyses. But the result is not uniformly positive. In the most conservative intention-to-treat analysis, where every incomplete phase was counted as a failure, non-inferiority was not established. Exacerbation rates did not differ, and symptom control and lung function were stable in both phases. So this is a signal worth watching, rather than a license to drop inhaled steroids, and the authors themselves frame it as an option for selected patients. That caution is reinforced by the French EAACI study published in the same journal, in which Portel and colleagues surveyed 970 adults with GINA Step 5 asthma treated in non-academic hospitals. Roughly 7 in 10 were on a biologic, most commonly omalizumab, yet close to 60% of patients had partially controlled or uncontrolled disease by asthma control test, and about 6 in 10 had at least one exacerbation in the preceding year. The most striking finding is the perception gap. Only about a third of patients reported full adherence, while physicians judged nearly 9 in 10 to be adherent. Anxiety symptoms were present in close to half of patients and depressive symptoms in about a quarter. The authors argue that closing these gaps in adherence, inhaler optimization, and comorbidity management could deliver gains comparable to introducing another new biologic. Finally, in the Journal of Allergy and Clinical Immunology, Shedkovsky and colleagues report a randomized, double-blind, placebo-controlled crossover trial of high-dose aspirin at 600 milligrams daily after desensitization in 14 patients with aspirin-exacerbated respiratory disease, with 13 controls. 8 patients responded to aspirin, but exactly the same number responded to placebo, with substantial overlap, and there were no consistent molecular changes after either treatment. Clinical improvement during aspirin therapy was, in short, comparable to placebo in this small trial. The positive finding was biomarker-related. Higher baseline sputum SER-PINB9 expression strongly predicted clinical improvement, making it a candidate for selecting who is worth desensitizing. On the upper airway, 2 studies address how much treatment is enough. In Annals of Allergy, Asthma, and Immunology, Chotmatry and colleagues randomized 70 children aged 6 to 18 with perennial allergic rhinitis to regular versus as-needed intranasal fluticasone furoate in an 8-week double-dummy trial. Regular dosing gave better symptom scores, visual analog scores, and peak nasal inspiratory flow at early time points, and greater reductions in mucosal eosinophils and metachromatic cells at week 8. But the clinical differences between groups were no longer apparent by the end of the trial. Cumulative steroid exposure was lower with as-needed use, adverse events were comparable, and epistaxis actually occurred only in the as-needed group. As-needed dosing improved symptoms from baseline too, so it is a defensible option for selected children who cannot manage daily therapy. At the other end of the severity spectrum, the World Allergy Organization journal reports real-world experience with stapokibart, an interleukin-4 receptor alpha-blocking antibody, in 37 adults in northern China with artemisia-driven seasonal allergic rhinitis uncontrolled on standard therapy. Using just 2 doses, 600 milligrams at baseline and 300 milligrams at week 2, total nasal symptom scores fell from around 9 at baseline to under 1 by week 4, and stayed low through week 16, with parallel improvements in quality of life, a marked drop in rescue medication, and suppression of nasal nitric oxide. This is an uncontrolled case series in a season-limited disease, so placebo and natural pollen decline both contribute, but a short-course, season-oriented biologic strategy is a pragmatic idea worth formal testing. Complementing all of this, a review in Allergy from Van Wyk and colleagues dissects why allergen immunotherapy trials succeed or fail, pointing to unvalidated primary endpoints, heterogeneous patient selection, low or variable allergen exposure, and large placebo effects, and calling for an internationally agreed minimal clinically important difference and publication of negative studies. Finally, on mechanisms, Choi and colleagues in Allergy analyzed 15-18 children from the Korean cocoa birth cohort followed to age 7, and identified 4 food allergy trajectories: no allergy in the large majority, early remission, early persistent in under 5%, and late remission. Children on the early persistent path had higher interleukin 4, 5, and 6 at ages 3 and 7, lower interleukin 10 at age 3 than the late remission group, and hypermethylation of 2 placental genes, RPS6KA2 and GCSAML. GCSAML methylation tracked with total and egg white specific IgE, early life eosinophils, and interleukin 5. It is association rather than causation, but it points to prenatal programming of who outgrows food allergy and who does not. If you only have time for one paper this week, make it the updated EAACI statement on drug hypersensitivity skin testing. It is the document you will actually reach for in clinic, and its risk-stratified pathway allowing direct provocation for mild maculopapular exanthema will change how quickly you can delabel. Here are the key takeaways from this week in Allergy and Immunology. First, test immediate drug reactions at 4 to 6 weeks. Use the standardized 0.02 milliliter intradermal technique with a 3 millimeter wheel increase as the threshold. And reserve preliminary skin testing for anaphylaxis rather than mild exanthema. Second, in perioperative anaphylaxis, early cutaneous vasoconstriction with bradycardia identifies the patients most likely to die, not the mildest ones. Third, before adding or switching a biologic in uncontrolled severe asthma, verify adherence directly with the patient because physician estimates substantially overestimate it, and screen for anxiety and depression. Fourth, aspirin therapy after desensitization performed no better than placebo in a small crossover trial, and sputum SER-PINB9 is an early candidate for identifying who benefits. And fifth, in mild type 2 low asthma, muscarinic antagonist monotherapy looks like a plausible alternative to inhaled corticosteroid for selected patients, but the evidence is not yet definitive. That's your roundup for this week in Allergy and Immunology. The full transcript and references are available on the episode page in your Audio Scholar library. This is an AI-curated summary. For clinical decisions, always consult primary sources and current guidelines. See you next week. If this weekly briefing is useful, follow the show in your podcast app so new episodes arrive automatically. And a quick rating on Apple Podcasts or Spotify helps other physicians discover the show. This is an automated summary generated by artificial intelligence, which can make mistakes. Always review the original source materials.